This is Dr. Priyadarshini, one of the mentors at StudyMedic, and today it's the KickStart series on postpartum module. Understanding the module of postpartum problems, the important topics to remember are the prevention and management of postpartum hemorrhage, which is given by the GTG guidelines, postnatal care, which is seen in the NICE guidelines, the antenatal and postnatal mental health, which is also a NICE guideline, postpartum psychosis, a very important TOG article, sepsis during pregnancy, the GTG, and bacterial sepsis following pregnancy, which is another GTG to remember. Also, maternal sepsis, a recent talk published in 2019, is considered important. Knowing also about neonatal problems and assessment, where the STRAT-OG gives the study material, is also considered important. What are the key points to remember in this module? Do not miss reading the GTGs. Of course, it's considered very, very important. Try to follow algorithms, especially for the management of postpartum hemorrhage, for screening and guidelines, and the treatment of mental health disorders, and in sepsis. Know the key words to differentiate the disorders because conditions, especially of the mental health, are not routinely dealt in the clinical practice, and hence applying these keywords helps us to determine or distinguish the differences. Always try to apply the cover test because, especially when you consider topics like mental health, the options are very, very narrow, and for us to get back to the right answer, applying the cover test is considered essential. Going on to the discussion of perinatal mental health, we have the guideline, and this guideline gives us recommendation for the recognition, assessment, the care, and treatment of mental health problems. This is going to deal with the women who are pregnant and also in the postnatal period up to 1 year after childbirth. And also, it covers women who are planning pregnancy. The main important disorders that are discussed are depression and anxiety because we see that it's seen in among 12% of women who have depression and 13% of women experience anxiety. They also affect 15 to 20% of the women in the first year after childbirth. Postpartum psychosis, though rare, it is just seen in between 1 and 2 in 1,000 women. Though it is very rare, it is considered as a very serious mental health disorder. Now, how do we start off with assessment and care plan? History of any mental health problem needs to be assessed, looking at the physical well-being of the women, looking at history of any alcohol or drug misuse, the woman's attitude towards pregnancy, whether she's denying her pregnancy, whether she's happy about it, the experience of pregnancy, and any problems that she has experienced by her or the fetus or the baby. How is the mother baby relationship? Any past or present treatment that she's taking for any mental health disorders, and what is the response to the treatment? What is her social networking like, and what is the quality of interpersonal relationship? These are factors which can help us assess the severity or the possibility of the women developing a mental disorder. Looking into family histories, especially first degree relative, if they have any mental health concerns. Domestic abuse, domestic violence, sexual abuse, childhood trauma all add up to the women of high risk of developing mental health disorders. Housing, employment, and economic factors are the other risk factors. Now, what are the key points to remember? You need to know how to ask and how to help the women. The how to ask, you have to make the first encounter count, establishing an appropriate rapport and using neutral open question to assess the severity of symptoms. Take cues and probe for any additional information if required. You need to ask specific and direct questions to establish risk. And of course, an active communication is required among the healthcare provider team between the obstetricians, the mental health midwives, the community mental health team, and the GP. And you also need to have a recap of what is her psychiatric illness like and her examination findings. Helping these women, we need to optimize all encounters to be therapeutic and to provide a front door lifestyle advice to support mild to moderate varieties. And we need to know about the referral pathways to refer them immediately when and how is admission required for them. Coming on to anxiety and depression. Now, consider asking about anxiety by using the GAD-2 scale, which is the Generalized Anxiety Disorder Scale. The questions that are asked here are, over the last 2 weeks, how often have you been bothered by feeling nervous, anxious, or on an edge? Or in the last 2 weeks, how often have you been bothered by not being able to stop or control worrying? Asking these simple questions, we'll get the score in the GAD-2. If the woman is going to score 3 or more, then we consider using the GAD-7 scale for further assessment or referring the woman to her GP. Or if it is a severe mental health problem, then we are going to refer her to the mental health professional. However, if the woman is going to score less than 3, but still you're thinking that there are some concerning features in her, then you can ask her again further questions. If she's going to respond positively, then we go on to apply the GAD-7 scale or refer her. Coming on to depression, again, we have simple questions to be asked like how long or how often have you been bothered by feeling down, depressed, or hopelessness? Or in the past 1 month, have you been bothered or not having any pleasure in doing activities? If the woman is going to reply positively, then we are going to apply the Edinburgh Postnatal Depression Scale or the Patient Health Questionnaire 9 as a part of assessment, or we are going to refer her to a GP, or if severe mental health problem, then the referral is going to the mental health professional. This is an example of the Edinburgh postnatal depression scale where we have questions, and based on the answer the woman is going to give, we are going to score her. Based on the score, we are going to see the level of depression and also the probability of referral to the mental health specialist. Now, what are the criteria or the conditions which requires referral to a secondary mental health service? Women who are having or suspected to have severe mental health illnesses, who have a past history of severe mental illness, which can be either during pregnancy or the postnatal period or any other time, or we have to be alert of the possible symptom of postpartum psychosis, which is very commonly seen in the first 2 weeks after childbirth. If the woman has sudden onset of symptoms which is suggestive of postpartum psychosis, then she requires an emergency referral to mental health service specialist, and assessment needs to be done immediately within 4 hours of referral. The most common therapeutic interventions that we use here are psychotherapy and use of drugs. Now, use of drugs, we need to remember we have to choose the drug which has the lowest risk profile, the lowest effective dose, use of a single drug instead of multiple drugs, and also the dosages need to be adjusted in pregnancy. All these factors need to be kept in mind. Risk of specific drugs. The most commonly used drugs are antipsychotics, lithium, benzodiazepines, and anticonvulsants. Going on to antipsychotics, they may raise the prolactin levels, and hence, for women who are planning on conception, this has to be kept in mind. Use of olanzapine is associated with development of gestational diabetes and weight gain in pregnancy, and clozapine is associated with developing agranulocytosis. Lithium is given special importance because it is associated with development of fetal heart defects. Epstein's anomaly is seen in 1 in 20,000 to 10 in 20,000 pregnancies. The plasma levels of lithium need to be measured every 4 weeks and then weekly from the 36 weeks. Ensure the birth is always in a hospital and monitoring the plasma lithium levels and fluid balance, because dehydration is very common and lithium toxicity can happen when there is associated dehydration. Now, stopping lithium during labor and checking the lithium levels 12 hours after delivery is important. Benzodiazepines, it is associated with cleft palate and other malformations. It's also associated with floppy baby syndrome. So we need to avoid use except in extreme agitation and withdraw very slowly. Use of anticonvulsants, carbamazepine, it is associated with neural tube defects. It is seen from up to 6 per 10,000 to 20 to 50 per 10,000. The other malformations that are seen with carbamazepines are the GI and cardiac malformations. Lamotrigine again is associated with oral cleft syndrome, and valproate is very commonly associated with neural tube defects. Now, valproate is generally not prescribed or avoided in women who are planning pregnancy or who are in the childbearing age group of a potential pregnancy. The therapeutic range of lithium is zero point 0.5 to 1.2 millimoles per liter. Going on to the various interventions that are available, depending on the severity of the disease, we have various intervention modalities. Two symptoms of depression. If the woman is having mild to moderate depression, then we generally consider facilitated self help to the women. Severe depression, who initially present with very mild symptoms, we consider use of drugs like tricyclic antidepressants, SSRIs, or SNRIs. If the woman has moderate to severe depression in pregnancy or the postnatal period, we have the following options. What are they? Use of high intensity psychological interventions like cognitive behavioral therapy or use of drugs like TCA, SSRI, or SNRIs. If the woman is already on a medication, then we need to consider whether we are going to stop the medication, continue this, or are we going to switch on to other therapy, which are generally considered safe in pregnancy. Now, all this should be done only by a multidisciplinary team approach. Going on to the Going on to diagnosis and management of anxiety. If the woman has got anxiety before pregnancy, especially like tocophobia, then we need to refer her to a specialist. If she has history of a post-traumatic stress disorder or a social anxiety disorder, then she will require some high intensity psychological interventions. If she's got anxiety disorder in pregnancy or in the postnatal period, then we usually start with some low interventions. If there is no benefit for almost 2 weeks, then we switch over to high intensity therapy. If the woman is already taking drugs like a tricyclic antidepressants, an SSRI or an SNRI, and then she becomes pregnant, we need to stop gradually and switch over to high intensity therapy. We can continue if she's going to prefer it and understand the risks, and if she's going to refuse other kind of therapy. Changing the medication, we need to switch over to single medication, the least effective dose, and also which is going to have the least risk to the baby and the mother. Combining medications with the high intensity psychological intervention is also considered good for these women with anxiety disorders. Psychosis. Psychosis, as already mentioned, this needs to be seen within 4 hours of referral by the mental health specialist. And also, admission to the mother and baby unit along with pharmacotherapy will help these women with psychosis recover better. For conditions like bipolar disorders, they will require interventions like cognitive behavioral therapy and psychotherapy and also behavioral couple therapy. If the pregnant woman develops mania or psychosis and if she's not taking any medications, then it is advisable to offer her an antipsychotic. If suppose she's already taking the prophylactic dose of medication, then we have to check and see what is her adherence to the medication and also increasing the dose of the antipsychotic. Suggest the change of this prophylactic dose to the therapeutic dose, and we can consider lithium if there is no response to an increase in the dose of the antipsychotics that has been used. Electroconvulsive therapy is usually considered as a last line of treatment if there is no response to lithium. The management of psychosis is considered important. Why? Because there is a risk of suicide and death which is directly related to psychotic disorders. What are the important red flag presentations? Any women who has these symptoms need to be referred to a secondary mental health service immediately for an assessment within 4 hours of referral. What are they? When the woman develops a recent significant change in her mental state or there's an emergence of a new symptom. There are new thoughts or acts of violent self harm, or there is new and persistent expressions of incompetency as a mother or estrangement from the infant. Now, whenever a woman who's got a who's known case or a suspected case of mental health problem and if she is referred, usually the assessment for treatment should be done within 2 weeks of referral and provide the psychological interventions within 1 month of initial assessment. But then we saw if the woman is suspected with a severe mental disorder, then the intervention must be within 4 hours of referral. Now, what are the important differentials that we need to see or consider in the postpartum period? We need to think about depression and anxiety, postpartum anxiety, panic disorders, post traumatic stress disorders, obsessive compulsive disorders, bipolar disorders, and most importantly, postpartum psychosis. Now, this is a flowchart which is going to give us the differences between all these, between postpartum blues, depression, and psychosis. These three are considered as the topmost diagnosis in the postpartum period. Blues is very common, it's almost seen in 26 to 84% of the women. There can be an associated of depression. The women is usually anxious with a little bit of depression in the postnatal period. But however, remember, though she has mood swings and cry spells, she is able to take good care of herself and the baby. There is emotional liability which is visible in postpartum blues. This postpartum blues is usually not considered as a psychotic disorder, and usually with reassurance and support, the postpartum blues get cured. Coming to postpartum depression, the prevalence is somewhere between 10 to 13%. The risk factors are usually a personal history of postpartum depression or a family history of depression. Now, these women usually have some stressful life events also, which can lead to depression, and few of them might also be taking some treatment already for depression. Now, what is the importance of knowing this? This women will need referral to a postpartum care, and some kind of treatment is required. This can be either in the form of psychotherapy or pharmacotherapy. Coming to postpartum psychosis, the prevalence of this is only 1 to 2 per thousand births. Excuse me. But the most important thing in postpartum psychosis or the differentiating feature is delusions and hallucinations. So, whenever a woman presents with delusions and hallucinations, we need to think in terms of psychosis. And again, it is important. Why? Because this is considered as a psychiatric emergency, which requires an immediate referral and treatment. Coming to other disorders like obsessive compulsive disorder, usually it is considered rare, and they have a past history of obsessive compulsive disorder which was either treated or on treatment. This is most commonly seen in primiparous women. So, in obsessive compulsive disorder, they have acts which are repeatedly seen. Say, for example, repeating hand washing, repeatedly checking whether the door handle is locked. These are some examples to diagnose or come to a conclusion of obsessive compulsive disorder. Coming to other common disorders that are seen or encountered are bipolar disorders. Usually, in bipolar disorders, there's a past history of bipolar disorder for which she's been taking treatment for. Again, in this, we see the woman is oversensitive, emotional liability is there, and also crying spells are very commonly seen in bipolar disorders. And coming to postpartum onset of panic disorder, this can be related to the childbirth. There is usually a prenatal disorder of anxiety or panic attacks. The support system is very low, and they have a very poor marital relationship, and there can be a history of domestic or a sexual abuse seen in these women. And because of this, they have panic attacks, and these panic attacks might be on treatment or might not be on treatment also. Post traumatic stress disorder because of a traumatic childbirth. Now, this can be again associated with a previous history of post traumatic stress disorder, which can be related to any childhood events or adult life events. There can be a history of abuse. There is very poor social support for these kind of women. However, if the woman gives that all this has started after delivery, then we also need to look into whether the delivery was a normal one, or did she have any traumatic events during childbirth. Going on to some questions which can help us understand the module better. Examples of some SBAs. Question number one. According to the published literature, what is the only obstetric factor that is consistently associated with an increased risk of postpartum psychosis? Now, we have various options like being a male infant, the maternal age more than 45 years, preterm deliveries, primiparous, and a ventouse delivery. Now, when we closely observe all this, we try to think that what can be the most common one associated with postpartum psychosis. Out of all the given explanations, the answer that most commonly correlates with this is being a primiparous woman. Now, what is the explanation? This is from the talk article, which says there's an increased risk of postpartum psychosis has been seen associated with a number of obstetric factors. They are primiparis, a pregnancy which has some complications, or there is some complications during delivery, delivery by cesarean section, having a female baby, and preterm deliveries are commonly associated with this. However, these findings are consistent only for a primiparis woman, and hence primiparis is the most suitable option here. A woman has had her first baby by cesarean section 7 days back. She is seen by her community midwife and appears to be low in mood and reduced appetite, and is sent to hospital for review. There is no suicidal ideation or thoughts to harm her baby, and she is diagnosed with mild depression. The women's case notes indicate that her mother suffered from bipolar disorder and has committed suicide. Now, what would be the most appropriate action? Now, in this question, what are the key factors that we need to take in mind? Factor number one, that she is in the postpartum period. She has had a cesarean section and she's already been evaluated by the midwife. What are her symptoms? Low mood, reduced appetite. But apart from that, she is fine. And also, we have one important thing is the close relative, that is her mother has committed suicide because of a bipolar disorder. So there's also a very strong family history here. Now, what are we going to do? Are we going to admit her for observation? Are we going to commence fluoxetine? Are we going to discharge to the GP? Are we going to offer counseling? Or are we going to refer her to the perinatal mental health services? Now, in this condition, though she has been diagnosed with only mild depression, the family history of bipolar disorder and suicide definitely puts her into a high risk, and there are high chances of her going in for psychosis. So, the most appropriate action would be to refer her to a perinatal mental health service. So, the good practice guidelines, which is developed by the RCOG, suggest that there are few scenarios which requires referral. What are they? There is a current history of severe psychiatric symptoms, or there's a history of serious postpartum illness, bipolar disorder, or schizophrenia, or she's on complex psychotropic medication schemes. And even if the woman has got mild or moderate symptoms which is developed in the late pregnancy or early postpartum, or she has got a mild symptom and a family history of bipolar disorder or puerperal psychosis, and that is the time we need to refer her. Coming on to the next question, we have a woman who's in her second postpartum week. She presents with history of confusion, bewilderment, delusions, and hallucination. She feels hopeless and care of the baby has been affected. So in this question, we see that the mother is also not well, the baby is also not fine. However, the key words to remember here are delusions and hallucinations. So whenever we come across such scenarios, we need to think in terms of postpartum psychosis. So, this is the distinctive clinical features, that is sudden onset and rapid deterioration of the conditions, and delusion hallucinations are very, very commonly seen in postpartum psychosis. Next question. Mental health disorders during pregnancy and postnatal period can have serious consequences on the health of the mother and her baby. It is vital that these women be managed by appropriate healthcare professionals. So, which is the healthcare professionals who are going to care for these women who have got a history of postpartum psychosis? Now, we need to understand that postpartum psychosis is a severe form of mental health disorders, and this will require a specialist intervention always. So, keeping that in mind, we have the options of community mental health team, which can deal with general mental health disorders or screening. Community midwife, again, she's going to be the first contact of the women, so she can screen and refer. General obstetrician or general practitioner, they can deal with mild varieties, something like a postpartum blue, or mild varieties of depression. However, for psychosis, it's going to be a specialist perinatal mental health service. So the answer is E. Because of psychotic severe disorders like psychosis, we need referral by the or treatment by the specialist. Coming on to the next question, we have a case of postpartum psychosis, which is considered as a psychiatric emergency, which usually needs admission. Now, what is the incidence of this in the general population? As I already mentioned, though this is rare, it is a very severe disorder. So, the incidence of postpartum psychosis is going to be 1 to 2 in 1,000 deliveries. So this is the study which shows us that the incidence is 1 to 2 per 1,000 births. Coming on to some EMQs. Now, usually EMQs are tested in such a way that you have a scenario and you need to pick up what is the disorder. Now, here I have various options given, and let's go into the questions. For each of the following clinical scenario, we need to choose the single most appropriate diagnosis from the list of options available. The options can be chosen once, more than once, or not at all. Going on to the first scenario, we have a 23-year-old woman who was seen 4 days postnatally in the obstetric triage after self-presenting after cutting a wrist at 3 hours. There is no ongoing bleeding from her injuries, and she is reporting that she just got upset as her boyfriend had been out and come home late. They are now joking with each other and appear very affectionate. So we have this woman who has cut her hand and she has come to the triage unit, but right now she appears very fine. So what can be the answer for this? Okay. Now we have various options like withdrawal of alcohol, amphetamine, which can again be drug abuse. Coming to other options like baby blues, bipolar, borderline personality disorders, depression, early onset of severe panic disorder, generalized anxiety disorder, obsessive compulsive disorder, postnatal depression, postpartum confusional state, puerperal psychosis, and schizophrenia. Now, going back to the question, we see she is in the postnatal period. Okay, it is just 4 days postnatal, and she has cut herself or injured herself. Okay, so the most appropriate answer for this is going to be option number E, which is a borderline personality disorder. Now, how do we come to this conclusion of borderline personality disorder? There are two important things to note. One thing is, she just says that she was very upset with her boyfriend and she cut herself, but right now they are very well affectionate with each other and they're just joking apart. So, this kind of a behavioral disorder or a behavioral change that is seen within a very narrow hours of time gap, is suggestive of a borderline personality disorder. Now, second scenario, we have a 31-year-old woman who's again 3 days post delivery and she is presenting with anxiety. Now, she is very frightened and she has some paranoid ideation that her family is trying to take her baby away. She has a history of schizophrenia but has been stable without treatment for 5 years. Now, what are the important key factors in this question? First point is she is post delivery 3 days. So she is in the postnatal period. Symptoms are anxiety and she also has some paranoid ideas also. And very, very important thing, she has a history of schizophrenia. Though she has not been taking treatment for the past 5 years, however, we have to remember that she has the history. Now, going on to the options that we have, again, we need to look and rule out the options. Now, keeping the buzzword or the keyword in mind, that is the idea of her family trying to take away the baby. Okay, so whenever delusion and hallucination comes into picture, remember we are dealing with a case of puerperal psychosis. Now, going on to the next question, we have a 40-year-old woman who is again 2 week postnatal after her first delivery. Now, she had a cesarean section and she has no past medical or mental health history. She has not been sleeping and she has been feeling very low and crying a lot. The baby has been readmitted due to excessive weight loss. Okay. Now, in this condition, if we see, she is in the postnatal period. Apart from that, she is all good. She is not feeling good, and also the baby is not been taken care of. Okay, so both the mother and the baby are affected, and she is almost 2 weeks. She has had a cesarean section. So, keeping all these factors in mind, the most common thing that we see in the postnatal period is going to be postpartum depression or postnatal depression. Coming to the last scenario, we have a 24-year-old woman who's delivered her first baby by cesarean. Now, she is seen in by the midwife 3 days after delivery, and she has been having some emotional instability, insomnia, and agitation. She seems to improve a little over the following 72 hours, but still she has got these symptoms on and off for the next 6 weeks. The baby is well looked after. So here we have a woman in her postnatal period. She has got some emotional instability. She is overwhelmed with what's happening with her. But however, the important point to note is the baby is taken good care of. So this kind of symptoms, which are usually, generally after the midwife's intervention, she is improvising. That means without any kind of psychotherapy, she's feeling better and doing better, and also the baby is doing fine. So this is a typical example of baby blues. So these are the answers. We had a case of borderline personality disorder, puerperal psychosis, which we diagnosed with delusion and hallucination, postnatal depression when the baby is also affected, and baby blues. The mother is okay, improving with some kind of intervention, and the baby is doing good. So, understanding the postpartum disorders and trying to differentiate among them is considered as a very key important point in this module of postpartum problems. So, blues, they are very mild and usually it's not considered as psychiatric problems and they usually spontaneously remit. Depression, they are moderate to severe and usually they need some kind of treatment. Psychosis is an emergency, it requires referral and hospitalization immediately. So, this is all about understanding this module of postpartum problems and in brief about the perinatal mental health disorders. Now, stay tuned for more such updates on our WhatsApp channel and also do follow us on Facebook, Instagram, Twitter, and LinkedIn. I've shared the links here. And this series of Kickstart for the MRCOG Part 2 students is really going to be of great benefit of those of you who are in doubt of where to start, how to start, or am I going in the right path. Wish you all the very best and thank you for watching this channel. You do subscribe and keep updated for more videos. Thank you.